Complications and caring for the patient experiencing complications during pregnancy is Chapter 6 in F.A. Davis. If you want to look in ATI, you can look in Chapter 7, Bleeding During Pregnancy, and Chapter 9, Medical Conditions, and then also a little bit of the end of Chapter 6, Assessment of Fetal Well-Being. So there's many complications that can happen during pregnancy. We're going to focus on a few. Bleeding complications that can happen in the first trimester, mostly. They can happen in any trimester. But most of the time when there's bleeding in the first trimester, we're thinking ectopic pregnancy or spontaneous abortion. Bleeding in the second and third trimester, you want to think more PlacentaPrevia or abruption, because remember, the placenta isn't really even sort of taken over until about, weeks 10 or so. Metabolism issues that can happen are type 2 diabetes, pre-pregnancy, or gestational diabetes, which is an insulin resistance first found in pregnancy. So gestational diabetes is what we'll concentrate on. Although many women come to pregnancy with both type 1 and type 2 diabetes. Perfusion issues we'll talk about are hypertensive disorders of pregnancy. Preeclampsia is one of the biggest ones that we'll talk about, but also there's women that come to pregnancy already hypertensive, which are considered chronic. Then there's gestational hypertension. Preeclampsia is gestational hypertension with signs of organ damage. Eclampsia is hypertension, signs of organ damage, and then seizures. And then HELP is a particular syndrome, and we'll talk about it. It's hemolysis, elevated liver enzymes, and low platelets, which can also happen as either part of hypertensive disorders of pregnancy or preeclampsia, or it can happen on its own. Blood type incompatibilities between mom and baby are RH and ABO. We've touched on them in the prenatal labs, but we'll get more into those as complications. So to go back to our first trimester bleeding complications, an ectopic pregnancy is any time a fertilized egg implants outside of the uterus. So we talked about fertilization happens usually in the fallopian tube, and then it travels down and implants into the uterus. An ectopic pregnancy is when it implants anywhere outside of the uterus. 99% of the time it actually implants still in that fallopian tube. So the patient presentation hallmark is going to be unilateral stabbing pain in the lower quadrant. So not, cramping, but a stabbing pain. That pain can be referred to the shoulder due to a ruptured ectopic pregnancy and irritation of the phrenic nerve by blood in the peritoneal cavity. So if anyone comes in and they have pain in their shoulder already, that's definitely going to be an emergent situation, and you're thinking that ectopic pregnancy has already ruptured. So unilateral pain, vaginal bleeding, a missed period, any abdominal tenderness, that should always be evaluated to rule out ectopic pregnancy. Risk factors include history of STI or sexually transmitted infections, pelvic inflammatory disease, any prior ectopic, prior tubal, any kind of issue with implantation or with implanting in the uterus can put a person at a higher risk for an implantation somewhere outside of that uterus, any kind of scar tissue. Treatment depends on whether it's ruptured or not. So if it's an unruptured mass that they're just lucky enough to find on ultrasound or, because of some issue with pain, methotrexate stops all rapid cell production, so it will inhibit the growth of the embryo. If a tube is ruptured, traditionally they would remove that fallopian tube via laparotomy. Currently, they'll do a incision to remove the pregnancy partially, and they'll remove that via laparoscopically. So hopefully they can save the tube, even if they didn't have to, or even if they couldn't save the tube. Education for you as a nurse is letting people know that you can still become pregnant if you only have one working fallopian tube. So this is going to be an emergency lab workup. So you're going to be starting an IV, you're going to be getting lab work, you're going to do a beta HCG, a blood type and screen, a CBC. So you want to be thinking, if you're seeing this type of patient, how am I going to react? What are they going to need? What do I do for them? So you want to be thinking about that when you're asked about it. So this is just showing you, this is the uterus where we want implantation to happen, and these are all just spots that there have been ectopic pregnancies. You can even have an ectopic pregnancy in the abdominal cavity. So there's various sites of an ectopic pregnancy, and again, depending on whether it's ruptured or not, you would either treat with medicine or treat with surgery. So other complications are spontaneous abortion. The definition of that is, spontaneous abortion is synonymous with miscarriage. It means the same word. What you're going to see in healthcare is spontaneous abortion, and that's pregnancy loss before the age of viability or pregnancy loss before 20 weeks. It's early if it's less than 12 weeks. Late is anything between 12 and 20 or 12 and 19 weeks, 6 days. Usually patients will bleed, they'll have cramping. If they get a lab test for HCG, it'd be a lower value than expected. So if you're 6 weeks pregnant, they have a value that they're expecting. Most of the time you'll get an HCG, and then you'll come back in 48 to 72 hours to see if it's holding steady or to see if it's going down. Because again, in that first trimester, the HCG, those numbers of that, because of the cell division, because of the multiplication, they're only supposed to be rising in that first trimester. So if they're lower than expected, or they're actually falling, that's something you want to look at as a provider and as a nurse. So risk factors, first trimester, usually they're chromosomal abnormalities. Infections can cause spontaneous abortion, any kind of immunologic or endocrine factors. They may not have any obvious cause. Second trimester, there could be chronic infection, recreational drug use, uterine, cervical defects, trauma, any kind of shock. The treatment depends on what's happening. So there can be expectant management. Sometimes dilation and curettage or DNC will happen. There are things such as a missed abortion. So sometimes women won't have bleeding or cramping. You just go in for an ultrasound and you see that there's no cardiac activity. And again, the treatment depends on the woman and her provider. They could take a watch and wait approach. Sometimes they want to just schedule a DNC. It depends on the provider and the woman again. If she is Rh negative, like we spoke about, Rh immune globulin, the RhoGAM, will be given to prevent antibodies. So it's a lesser dose for spontaneous abortion or miscarriage. But again, anytime that placental membrane can become compromised, you want to give an Rh negative woman RhoGAM so her body doesn't make permanent antibodies and doesn't permanently affect future pregnancies. So she will get a lower dose, but you are going to do a type-in screen to see if there's any issues and to see if there's that need for RhoGAM. It's very important with spontaneous abortion for Rh negative women that they're treated so they can go on to have healthy pregnancies later in life if they so choose. You want to assess her mental health, and you want to use therapeutic communication. You want to support, you want to, give her referrals to support groups, let her know it's not her fault. You just want to be careful with your communication and the way that you're speaking to your patient because it is a loss. So second and third trimester complications that you could see are PlacentaPrevia and PlacentaAbruption. Again, we talked about the importance of the placenta. It's acting as the lifeline for the fetus. So it's acting as its liver, it's acting as its lungs, it's acting as, gas exchange. It's helping prevent, infection, sort of protecting it from mom's immune system. So the placenta really is the lifeline. So when you have issues with that, you have to think about, how it's going to affect your fetus. And, you have to think about, at what point in the pregnancy, an issue is happening and what is happening. So with Previa, what that means is there's an abnormal implantation of the placenta. So it's implanted in the lower uterine segment as opposed to higher and up on one side. It happens in about 1 to 200 pregnancies. And how a patient is going to present most commonly is they're going to have painless, bright red bleeding. Because of small disruptions in the placental attachment and stretching and thinning of that lower uterine segment, you're going to see bleeding, but there's not necessarily going to be any pain for your patient. The placenta doesn't really grow with time, but it does sort of migrate up and off the cervix. So you can have a placenta previa early on in pregnancy, and it can sort of migrate towards that blood flow. Many times if patients have a placenta previa at their first ultrasound at 18 or 20 weeks, they might be provided with information on bed rest or pelvic rest, and then sometimes that placenta will migrate up and out of the way. We'll talk about on the next slide, if it doesn't, how you're going to care for your patient. But it is possible for a placenta previa or a lower placenta to sort of migrate out of the way. Placenta previa just means placenta before. So instead of, the placenta being sort of up here where you want it to be, it's down here covering the cervix. So you can imagine if that happened, completely, and it was, 36, 37 weeks, that's not going to be a vaginal birth because that placenta is in the way of the fetus coming out. So it depends on where you are in your pregnancy when you realize a previa is happening, what your treatment's going to be. So again, risk factors are a scarred uterus. So people that have had C-sections or previous abortions with cutting, they're at higher risk for placenta previa because of that abnormal implantation. Smoking, cocaine use, if you have a history of previa because of this vasoconstriction, and maternal age over 40 are all risk factors. So most of these women, they'll have a non-stress test, which is where they're put on the monitor for 20 minutes. They'll see how the baby is reacting to any kind of contractions. If she's actively bleeding, there's going to be, IV fluids, a lab workup, ROGAM's going to be given, again, bed rest and electronic fetal monitoring. Betamethasone would be given to promote fetal lung maturity if the baby is preterm, so if you're less than 37 weeks. If there's life-threatening maternal hemorrhage, there's so much bleeding, or labor can't be stopped, labor started and it can't be stopped, or there's signs of fetal compromise once you put the fetus on the heart tones and that doesn't look good, then they would do immediate delivery. Your education that you really want to know is that you're not going to do a vaginal exam to make any sort of bleeding worse as a nurse, and you're also going to teach patients the importance of reporting bleeding in pregnancy. So for the most part, bleeding in pregnancy is not a normal finding. It's always something that they want to report. And as a nurse, she has painless bright red bleeding. She comes in, she's 26, 27 weeks. You're not going to be the one that's giving her a vaginal exam to make that bleeding worse. So those are your takeaways. So again, this is just sort of showing you. So A is a complete previa. So the placenta is completely covering that cervix. B is a partial. So, that could migrate. It depends. And marginal or low-lying just means it's within 2 centimeters of that cervix. So, depending on, at what point you are, how pregnant you are, this baby's obviously not going to be born vaginally. This baby, if you had a few weeks and the placenta does migrate, possibly can be born vaginally. It just depends on where you are in the pregnancy and how much of the cervix is being covered by that placenta. So PlacentaAbruption is another placental complication. That is a premature separation of a normally implanted placenta from the decidual lining of the uterus. And that only happens about 0.3 to 1 time out of 100 births, but it does happen. It's something that you need to know about. The classic sign for third trimester placental abruption is bleeding and severe abdominal pain. So there'll be uterine tenderness, she'll have a board-like abdomen, fetal compromise. So if you put the baby on the monitor, you might see D cells, you might see low fetal heart rate, you might see a lack of variability. You might have bleeding or you might not have bleeding, depending on where the abruption is, which I'll show you on the next slide. So whereas painless bright red bleeding is almost always, you're thinking placenta previa, the difference between a placenta previa and an abruption is, for an abruption, your patient's going to have pain, and you might see blood or you might not see blood. It all depends on where the abruption is happening. And again, if this is our lifeline, if this is how the fetus is getting its oxygen and getting its nutrients and getting its, gas exchange and, getting rid of waste, and it prematurely comes apart from that uterus, you have minutes before that fetus needs to be born. So I'll just show you here. So there's mid-grade, moderate grade. So you can see how this little pocket's kind of up there. So, this might be coming off. You might not see any bleeding. Here it's moderately. So the placenta's, halfway coming off of that lining, and you're seeing an apparent hemorrhage. And then this is more than 50% coming apart. Placenta's separating, but you don't see that hemorrhage. So it depends. There's 3 grades. But for the most part, if you're feeling any kind of, board-like abdomen, uterine tenderness, and the baby's not really showing good signs, you're going to look on an ultrasound to see what's happening. Again, you're not going to do any cervical exams if you do see bleeding. So risk factors for an abruption are domestic violence, maternal hypertension, cigarette smoking, again, anything that can cause that vasoconstriction and can cause that placenta to come, detached from that lining of the uterus. Twins or triplets, cocaine use. So again, it depends on the type of abruption, what your care is going to be. Most of these women will get a non-stress test, which again is putting them on the monitor, putting the ultrasound on, putting the toco on, seeing what's happening during contractions, and it depends on the degree. So there's a lot of abruptions can be small. Sometimes you might not even see an abruption until, the placenta comes out after delivery and you see a small infarct, and, that's sort of, diagnosed retroactively. If there's active bleeding, you're going to administer IV fluids. Again, she's going to have a lab workup. She's going to be given Rogam if she's Rh negative. If she's preterm, she's going to be given betamethasone to promote fetal lung maturity. You're going to have continuous fetal monitoring on these patients, continuous patient support, and possibly a C-section delivery, depending on how the grade of the placenta abruption, how the infant's doing, how old the fetus is, etc. So your takeaway again is, if you see bleeding, you're not going to do vaginal exams. The differences between PlacentaPrevia and PlacentaAbruption are previa is, that placenta is before the cervix, so it's just previous. It's kind of where it's a little bit ahead of the baby, to say, or the fetus. And abruption is it's pulling apart. So if you think of the word abrupt, that's kind of like a harsh word. So an abruption is it's pulling apart from that uterus prematurely, which, as again, we talked about, if that's that fetus's lifeline, if that's how it's getting oxygen and nutrients, you only have minutes before you really need to deliver that baby and get it on the outside and have an external transition. So maternal mortality ranges from 0.5 to 5% with an abruption, and the degree of hemorrhage from the torn vessels varies. So you could have mild maternal anemia, or you could have maternal shock, acute renal failure, and death in severe cases. It all depends on, the degree of how much of that placenta is pulling apart from that uterus. So fetal mortality is about 35% in all. It can be as high as 50 to 80% when it's associated with severe placental abruption. Again, you only have minutes before that baby or before that fetus really doesn't have any oxygen supply.